Hey everybody, so I'm sorry that I'm late with the May wrap up. I was trying to make sure that we did May and it's a little bit too much, that we did May and June, kind of put it all together. And I was waiting for those meetings we had last week. So I'm going to breeze through the first part of it because we're going to talk about it in the June section. For those of you that came to the meeting, thank you so much. I appreciate it. I know it took some time out of your lives. But you should be all caught up in every training we've had up to now. If you did not come to the meeting, there is a packet with your name in the nursing office that just relocated downstairs by pharmacy. You need to go down there and grab it if you don't see the supervisor rounding. And please, there's a attestation and a antibiotics test that needs to be done, and I need all those turned in as soon as possible, okay? So we're gonna go ahead and start. Try to make this brief. It's a lot. If you came to the meetings, you know that, it took a really long time for us to get through the meetings. So we're going to start with May's wrap up. So pretty simple stuff. So welcome to the team. We've got a couple new MHTs. We got 3 new nurses that we're trying to get, acclimated and welcome them. They're helping us out, 2 on days, 1 on nights. And then of course we have a new nurse manager, Ms. Diane. If you guys haven't met her, she started in May. Please, make sure you introduce yourselves and again, treat them as someone you'd want to work with, right? They're here to help us. May survey, we're going to continue making sure that we get ready for joint commission. We're expecting a follow-up survey in the next couple months. And for those of you on day shift, you know that the state comes out pretty regularly to assess stuff. The med rooms in general are looking really great. The nurse managers, audit, pharmacy, myself, we all go in there every day and we check them and they look great. So please just keep doing what you're doing. Pain scores and reassessment, we're going to talk about this again a little bit later. Seclusion restraint, I'm going to review it on HCS with you and treatment plans, okay? So this is stuff that I've been telling you guys, and so we're going to go through it again. That's what we did at the meeting that we had last week, so that you guys know how to do it. Again, so for May, the best med room was Cottage A. So congratulations to the Cottage A staff, nurses who are going in there, making sure that everything is labeled appropriately, that all the logs are done, that just everything looks the way it should look. Most of the med rooms look really good, and so now I'm really just nitpicking how many things we gotta have to fix. If there's a blank, because you were off and your coworker didn't do rounds that night, then that counts, okay? So please, again, make sure you're still doing those nightly logs every single shift, every single night. If you don't know what I'm talking about because you're new, please touch base with a seasoned nurse or the house supervisor so that you make sure you're checking what you're supposed to be checking, okay? Labs, we're doing better with this. Please place the printed requisitions in the lab books. Nurses, day shift, please sign them off as you see, the phlebotomist going around and doing those. And please make sure you're verifying your orders, making sure you're checking them for every patient that you're assigned to make sure you didn't miss something, okay? We're going to talk about this as well. ER send-outs, they need a transfer order and then a med consult. We're doing pretty decent here. Daily notes, again, just a reminder, if it's at Q10 and high risk, you should be checking yes. And then the CSSR opens up. Treatment plans we're going to talk about. There's a new checklist in HCS that needs to be completed upon admission. And then, of course, the seclusion and restraint stuff. Omnicell, we're still seeing a couple discrepancies and overrides. I'm going to go through the one-time admin because I did that at the nursing meeting, and just make sure that you are reading the Omnicell specifically for what it's asking for. Sometimes it asks for the number before you pull your drug out, and sometimes it asks for the number after. So please make sure you're being very mindful of what it says, okay? And please, 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 please make sure you clear your overrides before you leave. Even if you didn't commit the override, you have to clear the machine before you leave. Otherwise, it's going to charge it to you as an error on your part. So if I didn't do something on day shift, someone comes in on night shift and they don't do it either, well, now it's my error and I'm their error, okay? So please make sure you're clearing it before. The nurse managers, and of course, are going around and making sure we're taking care of that. Continue to scan all medications. Oh, I missed to put the thing here, but we were at 90. No, we dropped a little bit. We're at 81% scanning meds. We did drop for the month of May, but please make sure you continue to scan your medications. We're going to talk a little bit briefly more about this. Patients should have HCS HCS wristband from intake. If they don't, let the house supervisor know, let intake know so that we can get you one. You're supposed to scan the patient's armband first, and then this HCS opens up to the patient profile. If you go to the patient's MAR first and then scan the armband, it's not going to count. Okay, right now we're at about 9%. We were at 7, we're at 9%. So we're supposed to be at 100% for this because this is a national patient safety goal from Joint Commission. This isn't ours. We didn't just make this up. This is a national goal. So remember, scan the armband first, then let HCS open up to that patient's MAR. I'm going to show you that in a little bit. Medication scanning, we're doing okay, 85%, pretty good. Again, our goal is 90%. Please continue to scan all those medications. If something's not scanning, please let pharmacy, the supervisors, myself know. We need to know what med and what dose doesn't scan so that they can then go in and fix it. We did find kind of a glitch on pharmacy's end with some of our medications. So we're looking to see if there's a way we can fix that so that this number goes up and you guys are better able to scan your meds. So everybody's name is listed kind of where they rank. If your name's not on here, then, you know, you're not hitting at least that 90%. So please, you know, be mindful, scan your meds. Observation rounds, we're doing way better. We're at 91.5%. Goal is 100. So we did increase by 4% month from April to May, which is a great job. Everybody is doing wonderful. Top round again was Cottage C. They've figured out the secret and they're doing a great job with those MHTs and nurses on C. Now, I mentioned this during the meeting, mention it here as well. Rounds is everybody's responsibility. So I'm going to go through how to do rounds. Nurses, you are expected to monitor your patients. If your tech goes on a break, you are responsible for those rounds. If you don't restart rounds on time, you don't catch that the tech didn't do them, whoever didn't do them for a couple of hours, you are just as in the wrong as your MHT, okay? So everybody's responsible. So please hear me clearly when I say that. Everybody is responsible for making sure rounds are being done and that we're monitoring our patients. So again, outliners here of where everybody kind of scored. Great catch, good catch for May is Miss Eden. She's an MHT, usually on the adolescent unit. She was able to identify that a patient was probably doing something they shouldn't be doing in the bathroom. And instead of listening to the patient, she kind of went in there and took control of the situation and was able to stop the patient from self-harming. So good catch, Eden. Wonderful. If you guys have a good catch and I don't catch it, please let me know. I'm only one person and I have eyes and ears everywhere, but I might miss something. So coming up, Impacts Committee, always looking for people. We're going to have those meetings in June, which just passed. Juneteenth, 4th of July is coming up, okay? 4th of July is a company holiday, so it is time and a half. We do still need staff if you're interested in working. So with that being said, I'm going to move on to what we're actually going to talk about, which is this one. So, okay. So we're going to go ahead and start with the actual stuff that, so this is June's, okay? So bringing it on back to what we talked about last week. So June, again, we have a lot of new hires, some repeat. Ms. Lila and Lakeisha came back to adolescents. We got 2 other nurses for day shift, Ms. Kimberly and Omatola, 1 for adolescents, 1 for Cottage C. So again, to help some more build some work. We have a new night shift supervisor. She's going to be offering additional support to the crew on night shift. So Ms. Kimberly is in training. And then of course we got 4 new MHTs, I think predominantly on night shift. So again, please make sure you help them feel welcome. So this is where we hit the actual meeting stuff. So if you didn't come to the meeting, this is what we talked about, all right? So upcoming surveys, we are expecting a follow-up backtrack. We are now accredited by Joint Commission, and we are accredited by a company called DNV. We went ahead and got double accreditation. So we're one of the few psychiatric hospitals in the city in Atlanta to be double accredited. So kudos to you guys. That means everybody's doing a really good job. And these people came out and toured through everything and made sure that we're doing great. So thank you. I appreciate everybody for all of their hard work. The only thing now, we just have to keep it going, right? They're going to keep coming. They're going to keep looking at our stuff. They're going to keep making sure that we're doing what we're supposed to be doing to provide good patient care. So for you guys, and keep doing what you're doing. We want to make sure that we're, you know, I have a couple listed here, checking the med room binders each shift, making sure we're throwing test strips in the biohazard trash, make sure the glucometer is being cleaned with the purple top wipes, continue to label the glucometers correctly, 90 days versus 120 days. There's signs in the med rooms, MHTs, making sure we're doing environmental sweeps and checks, pulling out any food, snacks, drinks, extra linen, hygiene, none of that stuff should be in the rooms. Make sure we're flipping those mattresses. So all of that stuff has to happen every single day, no matter how redundant and silly it might feel after a while, or how much it feels like it doesn't make a difference. It makes a huge difference, right? We always find something. So please, the minute you get complacent is the minute something happens. So continue to do that great work. We have added some more leads. You guys probably know them all by now. They're spread out on the different units. And so the point of the lead is to really start taking over precepting and training our MHTs in the way we want our MHTs to be, right? We all know, we've all worked with somebody that, this is what they learned on one unit, then they go to another unit, it's completely different. So we want to maintain that consistency and make sure that we have them doing the right thing. And then, of course, directing the unit in regards to, this is the structure we're providing. It's going to be the same. We follow these rules every single time so that we don't have patients that then come back and say, day shift, let me do this. Night shift, let me do that. The text yesterday, let me do this. The text today won't let me, right? That creates a lot of confusion for our patients and for staff. So they should be directing the units. Now, with that being said, they're not supervisors or managers, but they are responsible for making sure that the unit kind of flows a certain way. Please, we've already gotten complaints of a lot of resistance and a lot of pushback and a lot of, well, I've been here longer. Understood that you've been here longer. That doesn't mean you're doing things correctly, okay? Or that doesn't mean that you're falling in line with with a vision that we have for each unit. So again, we are open to conversation. If you have a suggestion or an idea, or if you want to apply to be a lead, that position is still open. But please make sure you're being respectful to the people that we hire and we bring in, okay? That you impact our retention much more than I do. And of course, we have our nurses, program nurse managers. For those of you that aren't aware, Ms. Diane is over at Cottage A and B. Tim is not a nurse, but he is there on C and C2 with myself and Stephanie providing support. Victoria is on E and Belinda's on F. So we really are trying to push to, if there is a unit specific problem, a unit specific issue, suggestion, maybe you think E would flow better a certain kind of way, that you bring it to your nurse leader, manager, Tim, whoever's responsible for your unit, because we want them to take more ownership and be responsible, okay? You shouldn't be calling the house supervisor for every little thing unless it's something for daily care, okay? I need a supply. I need, I ran out of snacks. We need snacks today. Okay, the house supervisor can help you with that today. Hey, we always run out of snacks. We never have enough. That sounds like a bigger problem that the nurse managers need to manage, okay? So again, just kind of, if you hear us kind of directing you back to them, it's not because we can't answer your questions, because we most definitely can. It's because we want to give people, we want people doing what they're supposed to be doing and managing their space, okay? Of course, you have Derek, Shawan, the house supervisors, which we are still trying to bring in a couple more to help. And then of course, Stephanie and myself. Documentation. So we're going to go through this, and I really hope it doesn't time out, because it has been doing that recently. Let me close out of stuff. Okay, so we're gonna go through this together as quickly as possible. Again, I'm more than well open to come and help. Now these are active patients, so I'm gonna try to not show too much as far as, HIPAA and stuff like that. Okay. So right now we're here. So the next thing on our, the next thing that we want to talk about is treatment plans. So nursing is responsible for putting in a psychiatric treatment plan on admission on every patient, as well as any medical conditions, okay? So let me start, and I might have already done one for all of these guys. Here's one, I guess. Okay, so let's say this is a dummy patient, it's not a real one. That's fine. With the guides So let me backtrack. In the nursing office, all of you have a packet that did not come to the meeting. In that packet, there is about 4 or 5 page treatment plan packet. It's printed on a different type of paper. It's in color. It's, you know, really good. I really recommend that not only when you pick it up, you keep it and you read it, because this is non-negotiable. When you bring your patient, you are all signing off that you did a build a treatment plan, but very few people actually are, okay? So not only is that falsifying documentation, but you're not completing your work, okay? So let's say, for example, this is my patient, and they come in for high-risk suicide, gonna strangle themselves. Maybe in the ER, they had a behavior to strangle themselves. So you go to items, edit problems. If intake has done their assessment, you will have under prospective problems a list of stuff that it automatically populates based off whatever the intake assessment said. Let's say this person went straight to the unit because they were, you know, it was too much intake. Fine. So we're gonna open edit problems, add a problem. My patient is here because they are a danger to themselves, and it'll bring up a bunch of different reasons. Are they psychotic or not? I'm gonna go easy, danger to themselves, psychiatric, inpatient, starting today, as evidenced by, so related to suicidal ideation. And then I'm gonna say attempted to hang self in ER, okay? That's all I have to do for that. Then I'm also going to add, because they're high risk, because they just did something, maybe they scored really high on intake CSSR. The ER is probably what, a couple hours since they got to us. That's high risk. So we want to make sure everybody knows, hey, watch out. So high risk related to, and you can put the exact same thing, and that is okay. Oops. So attempted to, sorry, hang self in ER. And I'm just gonna copy that, and I'm gonna paste it here, okay? Now, let's say this patient has high blood pressure, right? Almost all of our patients do. So I'm gonna add one. Now, nurses, this is taking us back to when we did care plans, okay? These aren't diagnoses, no diagnosis, these are all symptom-based, right? So hypertension, you know, you could do, there's one for cardiac, function impaired, related to, I usually just put previous diagnosis of hypertension. And we're gonna go ahead and we're gonna do inpatient, or you can do treat, whichever one is easier for you, is fine. Now, I do recommend you defer as much as possible. Thyroid, lipids, some asthma, HIV, cancer, stuff like that. We're not gonna do anything for them other than maybe give them their med in the morning, but we're not actively treating it. You can go ahead and put those as controlled. We have a controlled feature, or you can put it as deferred, okay? So this is treat. I'm gonna hit save and close. Now I have that in there. So now you've got the bones of the treatment plan in there. Now the next step is you have to add goals and interventions. Now this is where it gets confusing, okay? So I really recommend you guys pick up your packet and read the treatment plan guide. Keep it. It's very helpful. I didn't make it, so I'm not trying to sell you my stuff. It's very helpful. So danger to self. Nursing is responsible at goals and intervention for a short-term goal and at least 2 interventions, a doctor and a nurse. That's it, okay? So my short-term goal, like I told everybody in the meetings, I pick the ones that don't require me to do too much. So usually I pick this second to last one. Patient will identify 2 triggers for rapid decompensation that lead to rehospitalization and, okay? And then for goals and interventions, I scroll down until I see RN. There's only one. Well, that's the one we're picking. And then I'm going to pick the provider one directly above it, because it's usually the one that says I will educate the patient about their medication. Okay. So add goals and intervention. Short term, a week. In here, I put medication non-compliance, right? The patient will identify 2 triggers for rapid decompensation that lead or led to rehospitalization and medication non-compliance. Something happened that made them either stop their meds, or the meds, you know, stop their meds and come back to the hospital. So those are the one I usually go right here. The RN's gonna do this once a day, also once a day. This does say provider, so you should change this to, you know, whichever doctor it is, If you forget that, that's okay. That's an easy fix. I can go back in and fix later. Add goals and interventions, we're done with that one. Now, the high risk, any high risk, those are a little bit different. You do have to do the whole thing, okay? So high risk, add goals and interventions. Also made it really easy for you. Don't pick anything that doesn't have a whole sentence or a period. So patient will be stepped down from high risk to close observation, because we're gonna do that, right? We're gonna go from 10 to 15. In order to reduce patients' high-risk behaviors, patient will identify 2 protective factors. Before you discharge, you gotta tell us 2 things you're gonna do to not harm yourself. Then again, I scroll down, you're gonna pick the one that says place the patient on Q10, high-risk suicide, and that the provider will assess the patient for suicide within 24 hours. And then you're gonna scroll down and you're gonna pick screen. We're gonna screen the patient at least daily if they're suicidal. Those 3 you pick every single time. Every single time you do a high-risk assessment for suicide, high-risk treatment plan, you pick the same 3 things. This is outlined in that guide, which is why I say I really recommend you guys, not only you pick it up because there's tests, but you keep it and read it and use it until you get the hang of it. Q10, provider assess, and we're gonna screen them. Add goals, long-term, a week and a day, short-term, a week. Reduce the patient's high-risk behaviors of, again, what did they do? Attempting to hang self, overdose, ran the car off the road, whatever that high-risk behavior was. We put it here. We're gonna say we're gonna do this once a day, once a day, once a day. Again, provider says here, so we change this to whoever our provider is, and you hit save. That is it. That is the only psych treatment plan that you do need to fill out all 4 sections. Long-term goal, short-term goal, then 2 interventions. All the rest, you only do a short-term goal and then the 2 interventions, doctor, nurse. That's it. Make it easy on yourself. Pick the one that you know. Pick the one that has to do with meds, you know, because it's what you're doing. It's reflective of what you're actually doing, okay? And then, of course, medical, cardiac function, same thing, add goals and intervention. We do have to do the full thing. So 1 long-term, 1 short-term. I like to pick the ones that are finished so I don't have to type anything in. And then I usually kind of pick the ones, you know, the RN we're going to monitor for side effects. We're going to monitor the vital signs, monitor and educate. The provider's going to educate. And again, a week and a day, a week. If you happen to know what medication they're on, so Zestril, we're going to give it once a day, once a day, once a day. Some of these answers might be different. You might need to do ACNHS for blood sugars, maybe as needed if it's a pain pill. But, you know, in general, once a day is a good answer. And then again, test, you know, whichever provider is the one that, where's he at? Whichever provider is carrying the case. Add, and we're done. It is a little bit more time consuming. However, this is part of your initial intake assessment, okay? So hopefully you guys understand this. Restrictive interventions, I'm gonna go through this. We have added, so 2 things. I have noticed in the last couple months, nurses have gotten away from doing add favorites, and I'm not sure why you're making it harder on yourself, but please go back to this. We created this in order to help you. So you're putting orders for a new admission. Add favorite, physician admission orders, very first one. It already pre-selects everything that you need. You don't have to think about it. What ends up happening is we're having nurses put orders in one at a time. And when they do, usually one of these is missing. So then if it's missing, it doesn't get done. So then that chart's out of compliance, okay? So please, order favorites, pick this, it's all there. You can pick the flu, it's not flu season, so you can uncheck that one. There's another one for flu, where is it at? Right here, uncheck. This is a new order, medical bed use due to. F1, you have medical beds. F1 nurses, you would do a new admission, you should be picking that they're using a medical bed, okay? So I'm gonna add these orders to the patient. Again, let me pick the test doctor. So this is pretty easy, right? Inpatient, patient's a 1013. Here's where we're gonna pick those high risk. So he's high risk suicide because he just tried to hang himself at the hospital. High risk suicide, whatever other precautions apply. We're gonna do Q10s. Almost every patient, everybody should be coming in on Q10s until we have at least a little 24 hours to get to know what they're doing, right? Please don't forget a meal. This is the only way the kitchen knows that they're getting one. So restricted to the cottage. We said he had hypertension, so we'll do low salt. And then of course, this down here is your medical bed order, and you're just picking a reason why they need the medical bed. Patient displays difficulty moving to a sitting position. Hey, that sounds like probably what's wrong with my patient. Or, you know, head of bed, maybe we need to raise the head of bed for airway protection. The side rails used for turning. I usually pick one of these two. Press OK. Now your orders are added to your patient and you're not going to miss anything, okay? Because that is happening a lot more often now. And again, I'm not sure why. So while this loads, I'm going to move on to the next thing, which is the restrictive intervention. So again, add favorite. It's already down here at the bottom. You don't have to try to remember anything. Restrictive intervention, you pick, it automatically picks everything. I'm going to add those to my patient. Now this part here, pick the most restrictive one. It only lets you pick one, okay? So if they're in mechanical restraints, you don't need to pick seclusion. We already know where they're at. And I'm gonna put on here why the patient, you know, needs it. And then they're gonna, let's say they're still on the Q10. Great. So now when I go to my MAR, everything is here, right? So you see there's my admission orders, admission labs. Wonderful. We're not going to touch base on that. Most of the time, if it's here, you guys do them, or at least you sign them off. So not really a big problem here. There has been a slight increase in assessments not being completed and things getting missed. So please make sure you're at change of shift, especially if you didn't finish something, the oncoming shift is responsible for it being completed. Okay, so please make sure you're sharing that with each other. Here's seclusion and restraint. So what I want to show you, and I'll be brief. So the initial assessment is here. Usually we don't have a problem with this. Whenever I check all of them after a seclusion restraint. Usually where we start hitting a little problems is with our times. Please make sure your times all match. Please make sure that you close it out when you take your patient out. That happens a lot where nurses will put 000 as the time that it ended because you don't know when it's going to end. And you're just trying to save it, but then you don't come back and change it. So please make sure that that is updated. So really quick for this patient, mechanical restraints up for 4 hours. It does give you the option, if you'll notice here, if I do a manual hold and then a seclusion and then a restraint, it opens up a time frame for every single one, okay? So manual restraints, he went in there today, I'm gonna say, you know, at 1 o'clock, and let's say he's still in there, so he hasn't been released. So, you know, we put 000 just so I can save it. Then I gotta come back to it. Call the physician. Well, we called him, you know, maybe we noticed, you know, that he was starting to throw stuff a little bit before. And then of course, fill everything out all the way. Usually not a problem. Where we have our problem is this one right here. What time was the patient released? Because either it's on the next shift or you put 000, but then you forgot to come back, okay? I'm gonna hit partial save for that one because I'm not done, right? Debriefing happens after you take your patient out, not a problem. MHT flow sheet, if an MHT is sitting at the door, which they should be, then you can sign this off because they have to do this. It's part of their rounding, and I'll show you where that comes up. Nurses, so the 1 hour face-to-face. Now this is new because of our DNV survey. So at the very end, this red tag here, MD notification must occur right after completing the 1 hour face-to-face. That is new. We added that red blurb to let you know. So when I start this, so we said my patient went into seclusion at 1:30, right? Mechanical restraints. Your face-to-face should be exactly at the 1 hour mark. Now, if your patient comes out of seclusion, out of restraints before the 1 hour mark, and they're back out in the milieu in their room, asleep, whatever, then you would use that time if it's less than an hour. So let's say they're only in there for 30 minutes, then your face-to-face is going to be 30 minutes. It cannot be more than an hour, okay? So you do the hour. Again, this is where I say that the times kind of sometimes don't match. That's done. We go through the whole process, fill everything out, which if you've done this, it's a little bit much. You can copy and paste, which I do recommend, so that you can put everything in. Okay. whatever we're writing. Now, was the patient's physician notified? You are supposed to call the provider to get the order to put them in seclusion or restraint. When you do your 1 hour face-to-face, you have to call them again and say, Joe Schmo is still in seclusion. He's now in restraints, or he's still in restraints. He's not calming down. I don't think I can take him out, yada, 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 right? And then hopefully the provider will say, well, you know what? It's been an hour. Let's give him maybe some Benadryl because whatever we gave him earlier didn't work. Or you're calling to say, hey, just giving you an update. Joe calmed down after like 20 minutes. We took him out. Wonderful. So you hit yes. Then you put your attending, physician and the date that you were called. This time has to be after your 1 hour face-to-face. So this is where we kind of got that citing from the DMV, because it was unclear. Some nurses would put the order, the time they got the order. Some nurses put the time they did the face-to-face. It's supposed to be after. So if I did my face-to-face at 2:30, realistically, my face-to-face probably took me 5 minutes, maybe less than that, right? While I talk to the patient, depending how the patient's acting, fill out the paperwork, takes, and I call the provider. So realistically, my time here should be after the 1 hour mark. Okay. So that's what it's supposed to look like. Okay. And then after that, you see that it shows up 4 more times. And that is because you need, as an RN, you need to go and check on your patient every hour minimum. Okay. Now you don't have to call the provider after every single one of these. That's what this is for. You do your blurb, what is happening with the patient, they're still in there, you save them. Let's say we do the next one, when you get to the, he's in there for another hour, you would kind of continue, patient continues to be aggressive, threatening, whatever. Did you call the provider? No. Why not? No significant change in the patient's care, order's good for 4 hours. You don't have to notify them. Now, when you do take the patient out, then you would notify them and you would close out, the whole thing. So I hope this makes sense. If you have problems with seclusion or restraint, and I'm not trying to be funny, but cottage C2 and B do a lot of them. Those nurses are pretty well versed on how to handle this. So again, reach out to your coworkers and ask them, hey, I'm doing seclusion restraint. I'm a little confused on this. You can always text me, the house supervisors, and fill it out as best as you can, as correctly as you can with the times. I go in afterwards and I check them just to make sure we got everything, and I compare it to your MHT's rounds to make sure that it matches. But I'd much rather have to kind of change, a time by 2 minutes than having to figure out what happened, right? So please make sure you do this. If you have questions, let me know. Moving on, because I don't want Zoom to close me out. So ancillary orders, couple things. Every patient has to have an order for discharge. If your patient is discharging and you don't have an order, you need to call the provider and get a verbal order, and you put it in here, verbal order to discharge. Do not discharge a patient without an order, ever. The other thing is transfer orders. We send a lot of patients out to the hospital and we don't always have an order. Now I know you have one because I know you called the provider and you talked to them. And I had a nurse say, I thought the memorandum to transfer was the order. It's not. It's not the order. It doesn't count. Okay. So in here, really simple, go to add order, type in transfer, or start trying. And the second one that comes up, transfer out for medical care. Why? I don't know. Elevated, blood pressure, maybe you had a fall, whatever the case may be, just put it there, hit save. And now we've got an order in there and we're fine. Continue as you were doing, put in the memo to transfer as well. When the patient comes back, you put in a consult for medical to follow up with them just to make sure we're not missing something. The last piece actually a couple more things. So for the nurses, the last piece with HCS is rounding. So you are responsible for rounds. If your MHT steps off the floor, you are responsible for doing rounds. I understand if you're busy and you're doing something, then you and your tech need to communicate. You can't go on break right now. I can't come and relieve you on the rounds. Give me 5-10 minutes, whatever the case may be. But again, you should be communicating and you should be able to round. Now, the MHT said, the nurses say, that's not my job. Nurses, it is your job. You are responsible. At the end of the day, you are responsible for making sure your patients are being observed correctly. Prompt the MHT if you need to. Hey, what's going on? I need you to do rounds. When's the last time you rounded? The other thing that was mentioned was nurses say, I don't know how to do that. Well, you're in luck. I'm going to teach you how to do rounds, and it's really simple. So don't worry. But again, you are responsible. So I don't want there to be this, that's not my job. It is your job. I'm responsible for all 160 patients, regardless of if I know them or not, right? That is my role in my position. You as the nurse are responsible for all 30, 25 patients on that unit, whether you touch that patient or not, it doesn't matter. Because if something happens at the end of the day, what state, lawyers, police, everybody's gonna say is there was 4 trained employees on that unit to watch this person. How did this happen? You are responsible. We are holding nurses accountable for rounds not being done, okay? Because it's not fair to only hold an MHT responsible. Now, I do understand that you have MedPass and documentation and all these other things to do, but you should be aware of kind of what's going on your unit. The green check mark up here is rounds. If I go to rounds, and I'm not sure why it's being so slow. If I go to my rounds and I notice that, you know, if I happen to look over at and they look like this, that's a problem, right? If they're red, that means we're late. So this should prompt you to say, oh, why are we late? What we have heard, I mean, the nurses will say, oh, well, that's the tech. Okay, but you didn't notice that they didn't do rounds for 2 hours? Well, what happened? Okay, so if you see this, this should be a red flag for you and you should do something about it. Now, I'm gonna show you how to do rounds, okay? You click on your patient, you identify where they at. They are in the lobby. This one's late because I haven't done rounds in 4 or 5 days. I haven't used this patient. Technical issue, unit disruption out of facility, patient observed. Okay, we'll say IT issue and hit save. And just like that, I've done rounds. So again, you click on the patient, you identify where they are, if you're late, why you're late, and you hit save. Now, the next time I do a round on this patient, I don't have to pick why I'm late because now I'm on track. He's at the nurse's station talking to me. Save, moving on. It has a countdown of how much time you have left to do rounds, okay? So now everybody is well-versed on how to do rounds. Now, the next part I'll show you for the seclusion and restraints. Patient is in the quiet room. He is in seclusion. You saw that? A pop-down came up. This is why I say you can sign off the MHT flow sheet because the MHT has to put what the patient is doing. Okay, and then they hit save. So the next time that they do a round, the tech does a round, they can go back in and add the same thing. All right. Again, everybody's responsible for rounds. Please make sure you're documenting on your patient. Please make sure your patient is in the building that you're documenting on. Please make sure if your patient discharges that you're not doing rounds on them because they're gone. That means you're not doing rounds correctly. Now I'm going to go over some MHT pieces because we added this. So patient belongings, the green icon with the t-shirt, patient belongings. Please make sure that you fill this out, MHTs, when you're itemizing things. You have 2 options. We did ask for them to allow us to do more pictures. You currently have 2 options. Yes, personal items were collected. A giant page with every possible thing comes up. Please be as descriptive as possible. 1 belt, was it kept with the patient? No, it's in storage. And you go through the whole thing. Now at the bottom, you do have the option to add your own thing here. And it looks like they just allowed us to add more pictures, which I'm excited about. So you would hit get on the tablet and you can take a picture of the belongings. I recommend that you place them on a desk, kind of spread out so that we can see everything. Snap a picture, hit save. If you need more than 1 picture, you now have the option to do 2 and 3. Take a picture and hit save. As long as we can see what's in there, you don't have to itemize everything. Makes it so much easier and faster for you, okay? So please, please, this is not this. We need to know where people's stuff is. And then, of course, if possible, get the patient to sign. They don't want to sign, fine. You've signed that you check the stuff in, okay? The other thing with MHTs is rounds. I'm sorry, groups. You guys all do groups. You teach at least 2 to 3 groups a day. Please make sure you're taking credit. The 3 bubbles, the 3 Ps, the 3 dots, whatever this green thing is, click on that and this is your group note, okay? So what you're gonna wanna do is ungroup these patients. I'm gonna pick my unit, right? I'm gonna say C2, my group was 30 minutes. My meeting was about community wrap up at the end of the shift and the second shift, you know, discuss days, events, whatever you guys talked about. Very simple. If you fill all of this out correctly, click on my patient. It already comes up. They attended, participated, e-sign. Moving on to my next patient. Attended, participated, e-sign. Moving on to my next patient, e-sign. And if you notice, it moves my patients to me. So this is patient 3, attended, participated. Well, now it's patient 5. So you don't have to look, did I already do a note on them? It moves your patients forward. Okay, now I'm on patient 8. Attended, sign. And then I can keep going. Attended, but did not participate. Wonderful. And you can see my group is now listed on the bottom of these. Means I've documented on all my patients. And I'm done. I get credit. Patients got a good group and we move on. Okay. So again, please make sure that you are utilizing all of these functions. If you don't know how to do them, come talk to me. Come talk to him, supervisor, Derek Schwan, whatever, so we can help you. Okay. So with that, I'm going to stop sharing there, and I've only got a couple minutes left on my Zoom because it's going to kick me out. Okay, so last little piece that we want to go over, and I want to make sure you guys can see this. Here we go. Oh, well, I guess that made it bad, but okay. Okay, let me share this one with you. It's a little bit easier to read. Okay, so again, we went over this piece already. So moving on, defects. If you're a nurse on the adolescent unit, please restart their home meds upon admission. You still fill out the consent form and you send that to me, but you don't have to wait until consent is signed for you to restart home meds. So we have experienced a little bit of a gap there. Please restart. If you're confused about which meds to start, please reach out to me and we can figure something out, send that to DFACS. And then if it's not the right meds, they usually let me know and then we can fix it, okay? But home meds automatically need to be restarted upon admission. We send the consent. I usually get that the next day, and then we kind of go from there. Okay, don't wait. Scanning medication, we're at 81%. We did go down. Again, armband scanning. You have to scan the patient's armband first and then let HCS open up to that profile. If I'm already sitting on Bob's MAR, if I scan Bob's armband, it's not going to count as a scan. Okay, so we're at 9%. We need to increase this immensely. So scan Bob's armband first, let HCS move you to Bob's MAR, and then you can go ahead and pass those meds out. If you don't have an armband, you need to let us know so that we can get one from intake to put on the patient. I know they're going to take them off. I understand that. So there's always the possibility that we're not going to have enough stuff. But again, please make sure we're doing this process. We need to increase this percentage because it's pretty bad. 9% is horrible. Increase in med errors. Please make sure you have an order. Please make sure you're signing meds out. I get a lot of those. Trazodone was taken out of HCS, pulled out of the Omnicell. I don't see where there's an order in HCS. I don't know if it was administered or not administered. The other nurses gave me a list of stuff to fix with pharmacy, so we're working through some of those processes. Please make sure that you have an order for everything. You can do a one-time admin. I highly recommend night shift. You do a one-time admin. You don't have to wait for the pharmacy to verify the order. You don't have to wait for another nurse to co-sign and to check that it's been verified. Use one-time administration. If you don't know how to do that, ask a nurse who came to the class, ask me as a supervisor, and we can walk you through it. I really, really think that that is why we have so many, and it's mostly on night shift when pharmacy is closed. So you have to have an order for every medication you pull out of Omnicell. Period, the end. Okay. And we have to be able to, and you have to either administer it or write that you didn't administer it and what you did with the med. Okay. If it's wasted, then you put not administered, medication wasted on the one-time admin. Please make sure. Please make sure we're maintaining the unit schedule. Linens, we should only have one set of linen and 2 towels is the base for our patients. The more linens they have, the higher risk higher chance that they can harm themselves and kill themselves. Please make sure you're doing room checks and pulling extra out. Do not take the linen to the unit and leave it on the desk because that is considered an infection control. That whole thing of linen needs to be tossed. We've been going around this week and doing some re-education. You have to fill the yellow bin with the soiled linen. If it gets to the top, put the lid on the bin, and then there's some blue bags. In the soiled linen room, use a blue bag, put their linen in the blue bag, tie it up and put it back in the soiled linen. Do not leave plastic bags on the unit, okay? Don't leave them at the desk. They should not be on the unit at all. But please make sure we're disposing linen correctly. Please make sure you're reading signs. Cottage E has a sign on their cart that says, don't place linen on here. And every time we go up there, there's linen on there. So again, all of that stuff is annoying to find because we know everybody knows better. But it's the stuff that's going to get us in trouble when people around. Okay, so please make sure you're putting stuff where it goes. Time and attendance, please make sure you're clocking in for meals. If you take a meal break, please clock in and out. PTO needs to be in Paycom and Inovalon at least 2 weeks. I understand that it may or may not get approved, and I understand you're probably going to call out, and that's on you, and that's what decision that you and your pocketbook make. But for us, we need to have at least a 2 week, at least 2 weeks. So with summer coming, you know, as we enter the last of summer, people want to take vacations, which is wonderful, but all 5 people can't be off on the same time. So we're going to give preference to who puts it in first. Now, again, Stephanie, myself, and Tanya are the only ones that have access to Paycom, which means if you are on the schedule, but you're off and we approved it to be off, and then, you know, on the weekend, someone called and says, hey, we have you on the schedule, it's just an oversight. We forgot to take you off. There's 170 employees in the nursing department. It's a little hard to keep track of everybody. So please make sure you do it at both, okay? If you notice that you're on the schedule and you're not supposed to be on the schedule because you have PTO, shoot us a text before your shift so that we can say, oh crap, we missed you, and we take you off. Being on time impacts everyone. I read through these comment cards that many of the MHTs and some nurses filled out, and one of the things that came up there was lack of communication. So let me tell you, if you show up late at 8, 8:15, 7:45, the amount and the quality of communication and handoff you're going to get is going to be less than if you had come here at 7 or 7 in the, 7:10 in the morning or in the afternoon. I've been a nurse for over 20 years. I can tell you from experience, if my relief came at 7:30, my report sounded like, let's do count. You have whatever number of patients, everybody's fine. So-and-so got an IM, so-and-so's at the ER, have a good shift. And I'm leaving, okay? Because I'm waiting for somebody to come. I'm ready to go. Y'all are ready to go? They're ready to go, okay? So being on time impacts everyone. When you're late, you don't get a good report, and the shift has already started. I don't have time to give my MHT report at 8:15. I got report an hour ago. I'm passing out meds. You missed it. Figure it out, okay? So please make sure that you're on time, because it's a common complaint. I never get out of here on time. Everybody's always come whenever they want. Oh, we know. We know. Next part, customer service. We've had an increase in complaints of people just being mean and ugly to each other, being mean to coworkers, being mean to the patients. Now I understand that the patients are a different thing, and maybe it's true and maybe it's not. Understood. However, be mindful that this is a psychiatric hospital. Most of our patients are here on a 1013, which means they don't want to be here. Someone forced them to be here. They're already pissed off, right? I'm not saying we're catering to them, but we need to understand that the customer's always right? That mentality. What can I do? What can I help you? I can't help you, but you know what? Let me find out who can help you. Little comments, little laughs, little stuff like that, not necessary. That's the complaints that we get. Some of them are silly, and we know that, and we don't really pay too much attention to them, but after a while they kind of add and they build, right? So please be mindful how you speak to each other, to the patients. When you're answering the phone, please identify yourself. Hey, this is Amy, Cottage C2. How can I help you? I can't help you. You know what? Let me get your number. I'm gonna pass you on to da-da-da-da, because I know they can help you, okay? Or whoever it might be. Again, family members are stressed out. They can't come visit their family. They don't know what's going on. The doctor's not calling. All of those things, I understand that. Right, that's what I tell you. I understand that. How can I help you? Or this is the most that I can do for you. Okay. Then with each other, being rude and disrespectful to each other, we've also had an increase in this. So all of you are guys, one of the complaints on, your comment cards that you guys gave me, which I appreciate, I thought was a great idea, is we don't have enough staff. Why are you guys always shorting us? Why are you, first of all, let's clear something up. We don't short you. We don't short the units on purpose. We staff with what we have, and for what we have as far as patients, acuity, and the people that come to work, right? So one, come to work when you're assigned to come to work, right? So don't call out. That helps not being short. Another thing is being nice to each other. So when staff leave and they write their reasons for leaving, they don't write Amy was mean to me, Derek was a jerk, Stephanie was rude. Very rarely do they write that? What they say is the unit staff was rude. The unit staff didn't greet me. They didn't train me. They didn't talk to me. They have their little cliques. You can tell they were rude, dismissive, blah, 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 blah. Again, some of it's true, some of it's not. But we all know some of it's believable, and we know that. So you are the ones that affect people staying here. Okay, so understand that. So when you say, well, we're short, we don't got enough people, why don't you hire more people? We do. We interview about 60 people a month. Okay, we try to bring on the best people. Sometimes we fail. However, when they're here, it is your responsibility as coworkers to help keep them here. Okay, we're doing the heavy lifting, right? We interview, we call, we interview, we prep, we train, we try to do all of that. And then we bring them to the floor and we hope that they have a good orientation period. We hope that the staff on the unit are nice and respectful and helpful, right? So that we can keep them. We're hoping that that happens. And when it doesn't happen, it's really disappointing, especially if it was a staff that we feel that was actually going to work out, right? We're not perfect. We do hire some people that don't need to work here. Understood. But how you treat them on the unit affects if they're going to stay or not. So please be mindful of that. So next time you want to, you write, why are you guys shorting us? Well, hey, we had 4 new hires quit because they got here and said you guys were mean to them. So now we're stuck until the next month, until we get more bodies in the door, okay? So remember, all of that impacts all of that. Please understand, we are never short staffing the units for fun, okay? To save money, to do whatever you might think it is. Not happening. If you're worried about us hiring everybody that we need, don't be worried about it, okay? We need a lot of people. Don't be worried about it. There's plenty of overtime, okay? So those are all silly things that we have heard from people who no longer work here. Customer service, no Crocs. You guys have seen the signs all over the building, no Crocs. Period. The end. That's the whole message. Navy scrubs only, burgundy scrubs only for MHTs. We tried to do the black, and then some people kind of, again, took it too far. Leggings and cut out jeans. No. Navy scrub, burgundy scrubs only, jeans only on HR approved days. Okay. Not on Fridays. We don't do casual Fridays for nurses and techs. So scrubs only, navy, burgundy. Now, if your scrubs have a print on them, you know, maybe they're mostly burgundy, have a little bit of black striping, that's fine, scrubs only. Nurses, this is why I said you need to come by the supervisor office and get your packet. There is a DNB attestation that needs to be signed. Everything that's on there, I reviewed during this meeting. And then there's also an antibiotic training, about 7-question test. You need to complete that, and I need that as soon as possible. So please check the nursing office next time you're here to get those paperwork done. Again, we have a new nurse manager. We also have a new admissions nurse. So she is here every other week in intake. She is helping do admissions. Now, here's a perfect example. She's as sweet as can be, just got here. She already came to my office to complain about some of the nurses. They're rude, they're mean. Some of them called me and said, well, why didn't you do this admission? Why didn't you do that? She's here to help. She doesn't have to be. I can move her to a unit if it's better, but she is there because we identified a need to try to help with these admissions. So what she doesn't need is staff being rude and unappreciative of what she does do. Now, she has been instructed to help the hospital, not a unit. She wasn't hired to help with Cottage C's admissions. She wasn't hired to help with Cottage F's. She was hired to help with the entire hospital. So if A is getting slammed with 6 admissions and F is only getting 1, she has been instructed to focus on A, right? If E1 only has 1 nurse and they're getting 4 admissions, she's helping E1 versus C, who has 2 nurses and is getting 4 admissions. Does that make sense? So you have to think, we're thinking about the big picture. Where is she going to make the most impact? It doesn't matter if she helps with 1 admission on F when C's drowning, right? That doesn't help those nurses. So she's going to help where it makes the most sense. Now, she also, you need to be mindful when she's here, if you're doing what part of the admission she has done. Sometimes what she does is she does all the med recs and she gets orders for every patient that walks in the door. But that means she's not going to do the initial assessments, okay? Because those are more time consuming. Sometimes it takes a little bit slow. So she will do the entire admission, assessment, orders, meds, treatment plans, all of it. Okay, so you need to be, when you have that, she usually tries to communicate with the unit, hey, I did the admission, hey, I did the orders, whatever. Please make sure you're paying attention before you start putting the same orders in. I've had a couple charts that have have more than one and one set of orders, one set of treatment plans, stuff like that. So please be mindful, okay? And again, she's here to help. And she's only been here 2 months and has already come to my office to say this nurse was rude, that nurse was rude. They don't, they don't appreciate it. So again, you are the direct reflection of if people stay and leave, okay? So be mindful, she's here to help. I do appreciate these forms that you guys filled out. I did read all of them. I have a couple of things I'm following up on, so hopefully we have some changes soon. And we have a lot of good catches for June, so I wanted to go ahead and include them here. Obviously, we still got about 3 days left in this month, so who knows, somebody else might sneak up on here. So, a couple nurses on here, Nia and Rachel, escalating a wound to the provider. Amaru jumped the fence, lost a shoe, brought a patient back. Felicia Jakara found a patient who overdosed in the parking lot. They were able to help that patient quickly. Angelique, Alicia, Evany, all found stuff that patients had hidden. So great, insight, great assessment skills, and just knowing something was off. And then Robin escalated, a tank left in the parking lot that who knows what it was there. We don't care. It doesn't need to be there. So great job. I think you guys are doing wonderful. I appreciate all of you. If you have questions, if this was a bit too fast for you, you have treatment plan issues, charting issues, please come see me. Let me know. I'd rather you ask me than not, because I can most definitely walk through this with you guys. Okay, so thank you. Make sure you watch this video. Please hit the nursing office and get your pack if you didn't come to a class, because I do need those tests back as soon as possible. All right, thanks guys.